Today it is my pleasure to welcome you all here today to listen to Professor Whiteford deliver the 2015 Elkington Oration. Before I introduce Professor Whiteford, I would like to share with you the origins and historical significance of today's event. Dr. Jack Elkington was an Australian physician with a distinguished career in public health during the earlier part of the 20th century. He was born in Castlemaine in 1871 and enrolled in medicine at Melbourne University, and despite failing his final exams, gained qualifications in medicine and surgery in Edinburgh and London. He worked as a GP in Geelong before completing a diploma in public health at the University College London and a doctorate in medicine from Brussels. He was Chief Medical Officer in Victoria for 6 years before moving to Queensland in 1910 to take up the role as Commissioner for Public Health, during which time he helped frame the 1911 Health Act Amendment Act, which substantially expanded the scope of the Health Act, extending its public health focus. He was involved in responding to outbreaks of plague, smallpox, and also developed programs in areas such as sanitation, food hygiene, and child health. Then, when his and others' advocacy efforts to have a unified Commonwealth approach to quarantine was successful, Elkington moved to the newly formed Commonwealth Office of Quarantine, first as Director for Queensland and subsequently for Northern Australia. He advocated a national focus on tropical Australia and the islands and territories to the north, raising concerns for the well-being of the people who live there and the possibility of the introduction of infectious diseases into Australia. After an illustrious career, he retired in 1928, aged 57. Dr. Jack Elkington died in 1955, but a few years later, when a group of health professionals formed the Queensland Society of Health, the inaugural committee incorporated an oration to honour Elkington into its annual general meetings, and the first oration was delivered in 1958. The Elkington Oration has survived the Queensland Society of Health's incorporation with Australia and New Zealand Society for Epidemiology and Research in Community Health and the formation of the Public Health Association of Australia, and it is now held every 2 years to honour the work of Elkington in public health. In keeping with the spirit of Dr. Elkington, it is now our pleasure to honour the work of another distinguished leader in the field, Professor Harvey Whiteford. Professor Whiteford holds a position in psychiatry and population health at the University of Queensland. He has extensive expertise in psychiatric epidemiology, burden of disease estimation, mental health policy analysis, and service reform. Professor Whiteford is also the Director of the Policy and Epidemiology Group at the Queensland Centre for Mental Health Research. He leads an NHMRC Centre for Research Excellence in Mental Health Systems Improvement and is part of the Mental Disorders Expert Group for the Global Burden of Disease Studies. Harvey has held several senior clinical and administrative positions, including those of Director of Mental Health in Queensland and federal governments in Australia, and with the World Bank in Washington, D.C. His research interests are in epidemiology, mental health policy, and service planning and delivery. His research has had tremendous impact on mental health policy and service reform in both Australia and globally. Ladies and gentlemen, would you please welcome Professor Whiteford as he delivers today's Elkington Oration entitled The Global Burden of Disease Studies, Implications for Mental and Substance Use Disorders.
This is to honour Dr. Elkington, and I'm privileged to be here to do that. That was an inspiring summary of his work, and it's an honour to stand in his footsteps and give an oration which is in his honour. So what I'm going to talk about is the global burden of disease, specifically as it relates to mental and substance use disorders. And I can't do that without acknowledging the people who do all the heavy lifting. And as none of them are here today, I'll just quickly jump over that slide. And go on to the presentation. So, People would and may remember that the days before, or you all look, mostly you look too young to remember, the days before the global burden of disease and other measures of the health impact of conditions where we use mortality statistics to decide priority. Because everybody could pretty much count death, and even in countries with poor vital registrations and poor health services, most people counted deaths. What we knew, therefore, was what diseases were important based on the number of people they killed and the age of the people that died from them. So in the World Bank in 1992 developed a metric for the 1992 World Development Report, where Dean Jamieson, who was then the head of health, nutrition, population at the World Bank, asked two young, bright people, one from New Zealand and one from Australia, called Chris Murray and Alan Lopez, to think about a metric which could look at both morbidity and mortality. And that came up, which the metric which is now the disability adjusted life year. And that was an attempt to have a metric which allowed us to compare diseases which are very different. So it could allow us to compare road traffic accident sequelae from depression, from malaria, from cancer, cardiovascular disease, infectious diseases. And that was quite a big breakthrough at the time. And so we came up with the disability adjusted life year, which I'm hoping you know a little bit about, seeing this is a public health audience, and I won't have to go into describing what it is, but clearly it's the years of life lost through premature mortality plus years lived with disability in this single time-based metric. So assuming we know what it is, we will go into how it's been used. So before that, I'll say that the only metric around isn't the disability adjusted life year. There is the quality adjusted life year and various other measures which attempt to capture health loss. But it appears to be the one which tends to have a lot of traction with organisations such as the World Bank. So the first GBD study came out in 1996, although the GBD was, or the DALY was used in the World Development Report in 1993. So the first global burden of disease study was 1996, and there's been subsequent burden of disease estimates by the World Health Organization. And then in 2013, there was the GBD 2010, which came out, which was a complete recasting, the first big complete recasting of the global burden of disease estimates. And as you can see, more diseases, more injuries, more countries, more world regions. And this was developed not by the World Health Organization, but by the Institute of Health Metrics and Evaluation at the University of Washington, Seattle, where Chris Murray had moved to from Harvard with Alan Lopez, who was then at UQ. So this was a very big undertaking, funded largely by the Gates Foundation, but since funded by other sources. And it was done independently, although in collaboration with the World Bank and the World Health Organization. And the papers were published in a full issue of the Lancet in December 2013. And subsequent to that, there's been multiple publications around disease-specific groups, including mental and substance use disorders. What I'm going to talk about tonight is the GBD 2013, which is in the process of being published, as I said, but isn't all published yet. It's got a few more countries, 306 diseases now, and multiple world regions. So the big thing that happened when the GBD first came out was disorders which disable you but aren't attributable to premature mortality suddenly became much more important. And certainly that happened with mental and substance use disorders, happened with musculoskeletal disorders, happened for neurological disorders. The number of disorders in the first GBD were relatively small, that's the list. And they grouped large conditions together. So drug use disorders had all illicit drugs, and there was no child mental disorders in there largely, as you can see. That's the list that's in the GBD 2013, very similar to the list that was in GBD 2010, and many more disorders, including a lot of child disorders, as you can see, for those who know the diagnostic groupings for mental disorders. And given that the median age in sub-Saharan Africa is probably around 17 or 18, if you don't include child disorders, then you miss out a lot of disease morbidity. So we now have GBD estimates for those disorders for a disaggregation of the illicit drug use disorders, and we've taken out of GBD a lot of what have been considered neurological disorders, which are in the first group, and also dementia, which is now amongst the neurology group. But that's the grouping that there are estimates for at disorder level. So very quickly, so you don't get completely bored, I'm going to talk about the studies and how they go into the GBD, the prevalence estimates and how they're produced, disability weights, which have been somewhat controversial, deaths and how they impact upon this group of disorders and some other group of disorders, and why GBD isn't a very good measure of premature mortality in some populations, and then some implications. So to do the GBD for any group of disorders, you have to collect the global prevalence data. So to do that, you do a systematic review, as you would, and for this study, the systematic review is from 1980 to 2013. And there are certain criteria to get into the GBD, both to have a disorder included, because clearly not every disease or disorder is in the global burden of disease, and the quality of the studies needs to reach a certain threshold. And essentially for this group of disorders, we need population prevalent cases, so that it's a population study, which would be the whole of a country or a region of a country sufficiently large that we would accept that it was representative of the whole country. So it could be multiple catchment areas, a representative sample, or if it's a country like India or China, substantial subpopulations which are deemed to be close enough to the what the prevalence would be nationally to accept it into the data set. So having scoured the world grey literature and published literature, the number of studies which are in the Global Burden of Disease 2013 for mental and substance use disorders is listed there. You can't add those up because some studies have more than one. And you can see for some disorders, there's not very many studies, and for most studies, it's prevalence data. And for some studies, there is no data at all. And so that is the inputs. And that looks pretty scary, but given that this group of disorders perhaps hasn't had the epidemiological attention that other diseases have, there's no vital registration, and for many countries it's very costly to do population level estimates and have cases that reach the threshold for IDC or DSM diagnosis. Maybe it's not too bad, and certainly it's a lot better than it would have been 20 years ago. But that's the input data, and every disease, injury and risk factor will have a data set such as that, and we add to that in every update we do. So my team, who I remind you again aren't here tonight, keep a track of all the epidemiology that comes out of every country in the world, and that's stored in Seattle, and that team dials in through a VPN connection to the Institute of Health Metrics and Evaluation and runs the models for all the disorders in the mental and substance use group, with the exception at this time of alcohol, but alcohol we do next year. So in goes prevalence data, incidence data, remission data, excess mortality data, countries, regions, by age, by sex, and by the year that the study was done. And that data is combined, and we require DISMOD to not have missing data. So every country must have an estimate. And if you were to not apply that rule, you would have to assume that a country for which there was no raw data had no disease in those conditions. So, for example, there are many countries which don't have any raw data for mental and substance use disorders, and you would have to assume that the epidemiological parameters were 0, or you have to estimate what you think that country looks like, and DISMOD does that. So it will take data from countries that are similar geographically, socio-economically, have similar population profiles and other data, and impute data for that country, which is not raw collected data from that country, but is imputed data, with uncertainty, which is propagated throughout all the models. And it produces prevalence estimates for 20 age groups, 189 countries, and for males and females. It basically cascades from global prevalence down to super-regional, regional, down to country, and now we've gone down to regions within some countries, not within Australia, but within other countries. It tries to keep the data consistent using incidence, prevalence, mortality models, and it will tell you if it thinks that the inputs are implausible. I'll give you an example of that. For those of you who know about the DSM, it says that a disorder called conduct disorder in children can't exist after 18. By definition, it can only be diagnosed under 18. So you put into DISMOD the prevalence through the various ages that you have it, remission, and mortality, if you've got it, and then you tell it by inserting a prior that this disorder cannot exist after 18. And DISMOD runs the algorithm, runs the model, and then sends you an email, not quite an email as you would understand it, which says, you're wrong, you can't have this. You've given me the incidence that you have at the prevalence, you've given me the remission, and you're telling me that it all disappears when this person's 18th birthday. Epidemiologically, that's impossible. Which of course it is, because clearly it doesn't disappear. It's just the diagnostic and statistical manual saying you can't have it. So we've had to play with that model to allow things like conduct disorder to continue a little bit past the age of 18, because reality says that the disorder doesn't suddenly turn off at 18. It's just the way in which clinicians have designed the classification system. So we use priors to do that, and you can do other things. You can say there is no schizophrenia in the population before a certain age, etc. And the model allows you to do all of that. Okay, so if you do all of that, you will come up with outputs such as this, which is the point prevalence or 30-day prevalence for all the disorders, males and females, which are in the GBD. That's the prevalence. Figures. Then moving on to what you do with the prevalence data, you're then using disability weights to come up with YLDs, years lived with disability. So we know who in every population has the disease, then we want to know how disabled they are by it, and this is where it gets even more tricky. So for that, we have to have a disability weight. So a disability weight from 0 perfect health to 1 deceased is created for every health state, and disorders can have multiple health states. So major depressive disorder has mild, moderate and severe, Other conditions have asymptomatic, even though they're a prevalent case, because the person reports no impairment. And the proportion of the prevalent population in what's called severity splits is allocated to each one of those disability weights, as I'll show you in a minute. So how do we get the disability weights? Initially, they were done by health practitioners, public health people, in closed rooms in places like Geneva, which were criticised for being non-representative of what society believes those disability weights should be. And so for GBD 2010 and for GBD 2013, new disability weights were created. And they were done by case-wise comparisons of vignettes. So for hundreds of health states, which would cover a lot of the major disorders, vignettes were created, and then using pairwise comparison, individuals were asked in community surveys and an internet survey. 2 health states are presented, which person is healthier, and that was done tens of thousands of times to create a hierarchy of impairment, and that became the disability weights. So about 30,000 people from 167 countries were involved in that, and for 2013, more data has gone in, mainly from the European Centre for Disease Prevention and Control, which conducted further disability weights in Hungary, Italy, Sweden and the Netherlands. And some of the health states were revised. And some of the health states in GBD for mental and substance use disorders are quite different to the ones that clinicians and public health practitioners gave them in the earlier studies. In fact, the most disabling condition in GBD 2010, more than quadriplegia or severe intellectual disability or severe dementia, was acute psychosis. It was the condition given the highest disability weight. The other thing about the disability weight is it measures inside the skin, it's called loss of functioning. So it doesn't measure the welfare loss, the impact on the family and a range of other things. It measures the health loss. So let me give you a classic example of that. If you have a below-knee amputation and you happen to live in rural Pakistan, you may be begging on the streets to survive. If you have a below-knee amputation and you happen to live in South Africa, you might run in the Olympics and be a very wealthy person. For the purposes of GBD, the loss of that leg below the knee has the same disability weight. What we do about that as health systems, how well we can rehabilitate that person, what prostheses might be available and what difference that would make to that person's life is critically important, but isn't measured here. Otherwise, it would become almost impossible to adjust all the weights for treatment rates and for rehabilitation. So the raw weights don't take account of many things there to do with health loss. So here's an example for major depressive disorder. So there are the 3 vignettes. The raw disability weights given to those 3 vignettes, remembering 0 is perfect health and 1 is death, suggests that mild depression isn't thought to be too disabling. Severe depression is thought to be very disabling. That's a very high disability weight. We then take that prevalence population I told you about and we distribute that across those weights. 13% of major depression, people who meet case definitions, are not considered to be impaired at all. Nearly 60% have mild depression and only 10% get the highest disability weight of the total prevalent population. And in GBD 2013, as in GBD 2010, we don't do age weighting and we don't do discounting, which does affect this group of disorders. The average disability weight, therefore, turns out to be 0.22 for depression in GBD, but it's made up of that aggregate of disability weights and severity splits combined. And then that's done for all mental and substance use disorders and most disorders which are modelled this way. If we jump from prevalence and YLDs and disability weights, the other thing that goes in to a method where the cause of death on the death certificate is used, the primary cause of death is used, and the death is allocated to that disease group. So the only conditions in mental and substance use disorders for which there is YLLs, or cause of death, in the GBD is schizophrenia, anorexia nervosa, and the substance use disorders. There's no cause of death data for depression or anxiety disorders, any of the childhood disorders. And the number of deaths is very, very small. And that's a big problem because if you have serious mental illness and you're a male, you die about 18 years earlier. And if you're female, you die about 14 to 16 years earlier. However, the cause of death for those people is usually cardiovascular disease or cancer, or conditions such as suicide. But even in Australia, only 15% of the premature mortality in people with mental disorders is suicide. The rest is other non-communicable diseases. And the cause of death is therefore allocated to those disease groups. And in fact, suicide is allocated to injuries. It's not allocated to mental disorders. So most of the excess mortality, in fact, pretty much all of the excess mortality in people with mental and substance use disorders is allocated to other disease groups, which is on the cause of death certificate that the certifying medical practitioner writes and or what the coroner comes up with. I'll show you some ways to adjust for that towards the end. So the results for 2013. So to try and overcome some of the difficulties in accessing the data, IHME is making all this available publicly through a range of data visualisations which are on their website at that URL. And so diseases which strike young people and are disabling, and unfortunately mental and substance use disorders are a case study in those, make up a large proportion of disease burden for exactly that reason. They make it up through disability adjusted life years, and that's where it's counted. And so when we counted by mortality, we didn't really understand this to the extent that it's now quantified, and that's the big difference. And it's not just mental and substance use disorders, it's musculoskeletal disorders. Between 1990 and 2013, the big shift has been the lessening impact of communicable disease, infectious disease, and the move to non-communicable disease, and the growing prevalence of disability over premature mortality as a contributor. So the amount of disability that makes up the overall disease burden is getting bigger, and the contribution of non-communicable diseases is growing, and the contribution of communicable diseases and nutrition, reproductive health, all those are lessening as we're getting better at those, and we're getting more people are living longer and getting more non-communicable disease. Amongst the mental and substance use disorders, the biggest contributor is depressive disorders. That's about 30%, followed by anxiety disorders, The next group. You can see that. That's anxiety disorders there. Schizophrenia, alcohol. Bipolar disorder. So they're the big ones. And some of them obviously are quite small. And some of them are small because they're limited to certain age groups, such as the child disorders. The rate by age shows that mental and substance use disorders affect young adults. So this is 10, this is 20, 30, 40 for those who can't read the scale. And they have their peak prevalence in young adulthood, which is one of the reasons that they're most disabling. And so the median age of sub-Saharan Africa, as I told you, was in the high teens. And as that population lives longer, they'll start to live into, more of them will live into this age bracket, where they will develop more disorders of those age groups. Mental and substance use disorders, the first of the big 3 non-communicable disease categories, followed by cancer and cardiovascular disease. So this is another way that the data is visualised. If it's looking blurry and it's looking like it wasn't because you're short of caffeine or you had a good night last night with a contributed to the substance use disorder more epidemiology. So this colour here are the communicable diseases, neonatal diseases, and nutritional diseases, and you can see they mainly affect young people. The black is the mental disorders. The blue are neoplasms, cardiovascular disease, respiratory diseases, obviously getting much more important as people get older. This is musculoskeletal here. And so it's a way of representing the proportion of the total disability adjusted life years or burden by age. That's combined males and females. So that's another example of the visualisations we use. The burden differs depending on countries, as you would imagine, the big split between high-income countries and low-income countries. So mental and substance use disorders make up about just under 10% of the disability adjusted life years or burden for high-income countries, and just over 6% for low and middle income countries. For Australia, they make up just under 14%. This is called a heat map. This is another data visualisation. You can see that this is funded by a guy who created Microsoft. I think there's been a 45% increase in the burden of mental and substance use disorders from 1990 to 2013. It's largely driven by changes in population growth and age profiles. And the only areas where the prevalence has gone up are in substance use disorders, alcohol, and in conflict countries. So the rates overall have not changed that much, and they certainly haven't changed for mental and substance use disorders. And so while we might read about the epidemic of mental illness sweeping the country, epidemiologically it doesn't exist. More people are certainly turning up for treatment, putting their hand up, which is probably a good thing, but the population prevalence doesn't seem to have changed. Okay, so go back to the question about the YLL problem, and this is reworking what we have done for mental and substance use disorders, where we've taken the burden, the mortality burden of suicide, where we have psychological autopsy data to establish that the suicide was likely to have been caused by the mental disorder, and we've added that to the burden that's caused by the prevalence of that disorder itself. So for major depressive disorder, the blue is the burden of depression as I've described it in the method. The browny bit added on the top is the YLL contribution from people for whom suicide is believed to have been caused by their depression, and therefore we believe more accurately represents the burden of a depressive disorder, and we've done that for all disorders. And that actually moves mental, just doing that, not all the physical health deaths from cardiovascular disease and cancer or other injuries, but that moves mental disorders from the fifth to the third aggregate group of disability adjusted life years in GBD 2010, this data was done on. Last slide. Overall, the GBD 2013 says people are living longer, but there's more disability. We are living longer with less, but less healthily. There's a big shift from communicable to non-communicable, which is ongoing, has been ongoing for ever since GBD started to measure it. The methodology has been progressively improved, but is far from perfect. And it's only going to matter if we actually take the cost-effective interventions we know about and make them available through primary care settings in countries which are currently under-resourced in this area. But this group of disorders are disabling. They contribute, along with musculoskeletal conditions, as I said, the largest loss of human capital in those countries, and there is an economic return on investments in the health of this population. Thank you very much.